Yes.
Bismillah Rahman we are back with a weekly webinar on ERCP US. And this time we have a very eminent speaker, Dr. Waqar. You all know him. He's son of the soil. He's working in UK. And he's a very expert endoscopist and specialist in ERCP. He has been coming regularly to Pakistan and he has been mentor in teaching ERCP in the courses which are being conducted by which have been conducted by Dr. Saad Nihas for the past many years, and he has been instrumental in teaching and training in ERCP to the students in Pakistan. Um, the topic is anatomy of the ampulla. You all understand that unless we understand the ampulla, we'll never be able to do a proper ERCP, and understanding the anatomy, its applied anatomy in its optimal way, that gives us an assurance that we'll be able to do justice with our patients who are likely to undergo ERCP. If we understand the anatomy in a proper way, we know that we'll be able to deliver the interventions as well in the correct fashion. So today, Dr. Waqar, who's going to join us soon, I've just talked to him. He was trying to log in, and as soon as he logs in, I shall request him to start with his presentation. But just to emphasize the today's presentation, because the presentation which is going to follow next is the techniques of cannulation. Unless we understand the anatomy of ampulla, um, we must understand that we will not be able to understand the following presentation, following lecture, which is going to be on cannulation techniques. And Cannulation is all based on correctly understanding the different directions on which the CVD is moving, the direction in which the pancreatic duct is moving, the muscles which are there, and what exactly to do when you're finding it difficult to cannulate. My co-host Dr. Saad is suffering from upper respiratory tract infection flu. I know he's not well today. Saad, do you want to say something?
I think I totally agree with you. I think positioning of the ampulla and then understanding the ampulla is the key to successful, good ERCP, safe ERCP, because then you're able to cannulate better. Also, along with whatever else you said, when you get into trouble, you know where the vessel are, and you can actually work. And in case there is bleeding or any other problem, you know what to do. So I think ampullary anatomy as well as ampullary position both are key to a successful ERCP, because no matter how good you are, if you don't understand that, or you are unable to recognize certain, you're going to get into trouble and unnecessarily cause problems. So I totally agree with you. So, and Waqar has been, like you said, Waqar has been with me. I mean, Waqar and I go back to a very long time when we were much younger than what we are today, and it is actually Waqar who has made it possible for us to do the hands-on courses that we actually do in Karachi. Without his support, it would not have been possible. And then one after the other, we kept on getting like it happens in your unit. So I think lots of contribution and a fantastic colleague and an excellent ERCP speaker.
Oh, so we were talking about the anatomy of the ampulla. Pre-cut and cutting of the ampulla all depends on the anatomy of the ampulla, and then if a person starts bleeding, knowing the orientation of the different blood vessels around the papilla, they become very important, so that in case you have to apply the instruments for the hemostasis, that's going to help us in delivering the therapy, irrespective of whether it's a thermal therapy or some mechanical therapy in the form of hemoclips. If we know in which direction our vessel is running, we are able to apply the therapy in an appropriate fashion.
Also, Riyas, for selective cannulation, I mean, nowadays, if you want pancreatic duct or you want just the bile duct, you want to avoid pancreatic duct. I think once you understand this, it also helps you with that, and you're able to actually target the duct you want, which is what should be attempted most of the time. You should really not be getting into pancreas if you want the bile duct, or vice versa. That should be the aim. Obviously, it's not always possible, but it should be possible in majority of cases at least.
That's right. Regarding these webinars, we understand that these webinars are not a substitute to one-on-one meeting. The front-on meetings are always more instrumental in delivering the teaching. But as an alternative to COVID time, I think this is just an alternative that we have to follow.
Absolutely, I think it's a very useful thing because you're getting knowledge sitting at home in a very comfortable environment, relaxed environment, and you've selected some very good people. I mean, the lectures have been outstanding so far, almost all of them. So it's been very good learning for me, and I'm sure for relatively junior people, it should be equally good. I'm sure I can speak for myself, and I've enjoyed most of the talks that I was able to attend, and they were high quality, and they were very simple and simplified, and a lot of efforts went into the preparation, and also the question and answers were very useful, and also showed that the interest of some of our colleagues, both junior and senior. So great job, Prayas. All credit to you. So one of the issues with people like Waqar and myself is that technology quite often beats us by miles, and we're generally not so. Aage Waqar?
Apologies for delay, but Dr. Waqar is trying to log in, but he's
this is what I was saying. That
we're sending him the link again. I've sent him the link once, but sending him the link again. I've asked Dr. Said to send the link.
I was just telling the participants that this is something that I think Waqar and I would fall into, and we are not so technically, this advancement that has taken place is very difficult to keep up with all these technical devices, etc.
Assalamu alaikum. Warm greeting from Manchester. Thank you very much, Gayas or Saad Bhai, for asking me to speak on this occasion. We are basically discussing the anatomy of the ampulla of water, or Vater as the Germans would call it, and its relevance to ERCP. Ampulla, basically, as you all know, means a flask-like dilatation, which is or a tubular structure. Vater was a German anatomist, Abraham Vater, or as they pronounce as Vater in Germany. And he described the anatomy of this structure. It is the major duodenal, where the dilated junction of the bile and pancreatic ducts enter the duodenum. The ampulla is surrounded by a band of muscle fibers. It's a specialized muscle fiber known as sphincter of Oddi, which you are all familiar with. And the main function of the sphincter of Oddi is it controls the flow of bile and pancreatic juice to the duodenum, but it also performs a very important function of preventing reflux of duodenal contents and bile and pancreatic juice into bile and pancreatic ducts, because if they get refluxed in at the wrong time, they can cause havoc like pancreatitis or infections like acute ascending cholangitis. This is a diagrammatic representation of the ampulla of water, and you can see, it's a dilated sort of structure with the common bile duct and pancreatic duct joining together. Sometimes they join empty into a common chamber. At other times, they are separated by a membrane or a septum, and at times they open independently into the duodenum. And as you can see, there's a sphincter of Oddi muscle which is surrounding them. The sphincter of Oddi covers the papilla inside the duodenal lumen, but it also covers surrounds the pancreatic duct and the common bile duct, especially the common bile duct up to a certain distance intramurally in the duodenum. This is another diagrammatic representation or a model representation of the anatomical structure, where you can clearly see the ampulla of water, where the main tributaries are the common bile duct and the pancreatic duct, and you can see the accessory pancreatic duct and emptying the minor papilla. And this is into the second part of the duodenum. Just another picture to reinforce the anatomy. The ampulla is about 1.5 centimeter long. But the length obviously varies from individual to individual. It traverses the duodenal wall. It travels intramurally and opens into the duodenal lumen through a major duodenal papilla. The papilla of water, which is the projection inside the duodenal lumen, is about 0.5 centimeter. And sometimes there are mucosal folds inside the ampulla or the papilla, which are known as valves of Santorini. The main function of the mucosal fold is to prevent regurgitation of fluid. The ampulla of water and the papilla are located in the second part of duodenum. So it is important to reflect or review the duodenal anatomy as well, and the anatomical relations of the duodenum to the other structures. The first part of duodenum, or the duodenal bulb, which is part of the first part, is connected to the undersurface of the liver. So it's in close proximity to the porta hepatis. And there is a connection actually with the hepatoduodenal ligament, which carries the vascular structures like the portal vein, the common hepatic artery, and the common bile duct. Now, the quadrate lobe of the liver and the gallbladder are also in close proximity to the first part of duodenum, and in fact lie in front of them. Those of you who do EUS are very familiar with those landmarks. The common bile duct and the gastroduodenal artery are behind the first part of the duodenum. Now, this is another image just to reinforce the anatomy, where you can see the common bile duct, the gallbladder, the liver, everything are very closely attached to the first part of the duodenum. Whereas the second part of the duodenum is in close proximity to the head of the pancreas. In fact, the head of the pancreas lies in the lap of the second part of duodenum, which is known as the descending part also, is about 10 centimeters long. It has an upper and a lower flexure, or genu. The transverse colon, the transverse mesocolon are in front of the duodenum. That is important to know when you are thinking about anatomy and when you are thinking about the various complications that one can come across. The right kidney and inferior vena cava are behind the duodenum. And as I mentioned, the head of the pancreas lies within the lap of the duodenal. Another image to give you idea of there, the transverse colon has been resected, and you can see the duodenum. There is reflection of the peritoneum on the duodenal surface. You can see from the reflection of the parietal of the peritoneum that the duodenum is a retroperitoneal structure. It does not have a mesentery. And you can see the pancreas is also retroperitoneal. Above, you can see the celiac trunk coming out of the aorta, and you can see the inferior mesenteric artery and the vein running along it. The duodenal papilla in its own right is a slight elevation on the duodenal mucosa, which you see as a bump. It's a very familiar picture when you are doing ERCPs. Located about 8 centimeters distal to the pylorus, and during ERCP, when you shorten your scope, you come right across and face on to the duodenal papilla. In fact, the site of the duodenal papilla marks the junction of the embryological development of the foregut. And now, just for anatomical completion, the third part of the duodenum runs from right to left in a horizontal fashion in front of the inferior vena cava and the aorta, with the superior mesenteric vessels in front of it, as we just noticed in the picture above. And the fourth part of duodenum continues on into the jejunum, which is at the duodenal jejunal flexure. So this is just to give you a background of the duodenal anatomy. And as I mentioned earlier, except for the first part, the duodenum is largely retroperitoneal and therefore fixed. It has no mesentery and is covered by peritoneum only on its anterior surface. Again, to reinforce the anatomical picture, just a brief few words about the sphincter of Oddi. It consists of three basic components, which is the sphincter choledocus, or the sphincter around the fibers around the common bile duct, the sphincter pancreaticus, or the sphincter fibers around the pancreatic duct, and the sphincter ampullae, which covers the ampulla as a common sphincteric band. Of all these, the sphincter choledocus, or the sphincter around the common bile duct, is the best developed and regulates the outflow of bile. It is important, especially when we are doing sphincterotomies, because unless and until the sphincter of Oddi is completely excised, the sphincterotomy is not effective. And it prevents free communication between the bile and pancreatic duct, and also between the bile duct and the duodenum. So a more closer picture of the sphincter of Oddi as it comes. This is the one which covers the common ampulla. That's the part of the sphincter of Oddi which covers the common bile duct, and the part that covers the pancreatic duct. It does not communicate with the longitudinal and circular muscle fibers of the duodenum, the duodenal wall. It is independent band of muscle fiber with its independent innervation. A more diagrammatic representation, just to enhance the concept of this independent sphincter in the common bile duct and in the pancreatic duct, and the common sphincter around the ampulla. The duodenal papilla lacks the muscularis mucosae and submucosal layer, just like the gallbladder, but the sphincter of Oddi consists of a thin, smooth muscle. And as I mentioned, it is at the distal end of the pancreatic and bile ducts. Now, the duodenal papilla, according to Lindner, when he did his studies in over 1,000 patients, he found that in the overwhelming majority of the patients, the duodenal papilla, as we all know, was located in the descending or second part of the duodenum, in almost 82%. Occasionally, it was further down distally at the junction between the descending and horizontal part of the duodenum, and very rarely in the horizontal part of the duodenum. On a personal basis, I've not really come across the distal most location of the papilla in the horizontal part. But yes, you do see them sometimes a bit more distally. Just to recap, that's the duodenal bulb, superior part, descending part, or an horizontal part. The location of the papilla is around here. When observed through the endoscope, which we normally do through our side-viewing endoscopes, the major duodenal papilla is a hemispherical or oval elevation or a knob. The shape of the papilla varies from person to person. It's very individual, and we'll briefly discuss that as well. There's a circular fold at the oral side of the papilla. Normally, to describe the structure, we describe it as oral or anal side. There's a circular fold at the oral side, and then a further fold, which is called the hooding fold, covers the duodenal papilla, as you can just make it from the picture. That's the oral side of the papilla, and this is the anal side of the papilla. So on the top, on the oral side, there's a circular fold, and then usually there's a second circular fold, which is also known as the covering hood, and that covers the papilla. And then there's a longitudinal fold, which comes from below, from the anal side, and that's known as the frenulum. And it's usually a good marker or indicator for the location of the duodenal papilla when it's not easily visible. And this is a more diagrammatic representation of the papilla, just to enhance the concept of the oral, the circular fold, the covering fold, and the frenulum and the sulcus in between. Again, a further diagrammatic representation, it just shows the papilla. the folds are the infundibulum, or this is the intraduodenal part of the ampulla, and the frenulum. Now, in the ampulla, the pancreatic and bile ducts are located at the duodenal papilla with the choledochal duct. About 70% of them form a common, empty into a common chamber and form an ampulla, which is a dilatation at the terminal end of the pancreatic and bile duct when they join into a common chamber. However, it varies from person to person, and there are three possibilities. There can be, the common bile duct and the pancreatic duct might open separately, independently in the duodenum at the papilla, or they might be joined into a common chamber but separated by a partition, and then those that form a common duct. So if diagrammatically, if you look at it, this is the one where it's opening independently by two separate orifices into the duodenum. This is where they are running together in the ampulla, separated by a septum and opening right at the tip commonly. And then this is where it opens into an ampulla of water as a common chamber. In the majority of the cases, they open in about 70% of the cases, they open into a common chamber. Now, after discussing the anatomy of the papilla and the relations of the duodenum, I would just like to briefly mention about one of the major complications of ERCP, which is post-ERCP perforation. And there are 4 different types of perforation are described in association with or as a complication of ERCP. The first one, type 1, is the lateral or medial wall perforation of the duodenum. This is mostly caused by the manipulation of the endoscope. It can be either by violent swings of the tip of the endoscope, or at times, or especially when one is trying to manipulate an endoscope into position and there's a diverticulum, it might cause a tear in the diverticulum. Or it can be when there is altered anatomy like Biliary 2 stomach, it is possible that the loop of the duodenum formed in the stomach might cause a tear, either in the stomach or in the duodenum. So that is the one which is usually associated with maximal sort of contamination, and the tear is quite big as it's caused by force of the scope. Then there is the typical one, which is the Periwaterian injury or Periumpulary retroperitoneal perforation. In this is typically associated with needle knife sphincterotomy. Usually the person either does it in the wrong anatomical, perform the sphincterotomy in the wrong anatomical plane, or goes too deep. And this is the one which causes a perforation into the retroperitoneal space. This can be associated with just leakage of air, and at times, if you are lucky, it might seal itself off, but it becomes significant when there is fluid or bile associated or duodenal contents associated with air into the retroperitoneal space. That might require surgical or percutaneous drainage and treatment. Then there's the type 3 perforation, which is the distal bile duct injury, and that is related to manipulation of the wire basket instrumentation or due to performance of therapeutic procedures like sphincteroplasty or even sphincterotomies. This is the one where there is minimal contamination and might require at times just conservative treatment, or at times it might require stenting of the bile duct. Number 4 type of perforation is the retroperitoneal air on its own. This is usually an incidental finding on abdominal X-ray or CT scan when the patient might complain of some abdominal discomfort and the radiological examination is performed. They might detect retroperitoneal free air. this usually does not require any intervention. The patient has minimal symptoms and it would get better on its own. Now, another complication which is related to the papilla or the ERCP is hemorrhage. Arterial bleeding fortunately, from the major duodenal papilla is an uncommon complication, but sometimes potentially it can be life-threatening. Most of the time, the bleeding which is observed after sphincterotomy settles on its own or might require minimal intervention, but very rarely it might be life-threatening and may require more active intervention like interventional radiologist or surgical intervention. Now, just to give you a background of the arterial supply of the papilla or the duodenum, the blood supply of biliary system originates from the celiac trunk, which is a major branch of the abdominal aorta at thoracic 12 level. It gives rise to splenic artery, the left gastric artery, and the common hepatic artery. The common hepatic artery, of course, is of interest to us because that, in this context, supplies most of the oxygenated blood to the liver and also the duodenum. Now, the gastroduodenal artery is a branch of the common hepatic artery. It runs down behind the first part of the duodenum in front of the pancreas. So it is basically wedged between the duodenum and the pancreas. And it gives off two important branches, which are the posterior superior pancreaticoduodenal artery and the anterior superior pancreaticoduodenal artery. So they've basically, if you can see, the celiac trunk, the hepatic artery, gastroduodenal artery, and that splits into the anterior superior pancreaticoduodenal artery and the posterior superior pancreaticoduodenal artery. And they form an arcade around the duodenum. And then likewise, from the inferior, from the superior mesenteric artery, which is lower down, inferior, anterior and posterior pancreaticoduodenal arteries branch off, and they form a sort of plexus around the duodenum and pancreatic artery. Now, there is a very close association between the blood supply of duodenum and the pancreas. Therefore, even when surgical procedures are considered, duodenal and pancreatic surgery take place together. So just to recap, the inferior, as I mentioned, pancreaticoduodenal artery arises from the SMA and bifurcates into anterior and posterior, and then they join the superior corresponding arteries. And they, so anterior and posterior pancreaticoduodenal arcades are formed in the anterior and posterior pancreaticoduodenal grooves. So they then supply direct branches are vasa recta duodeni into the duodenum. We'll just go back again. So those are the end branches that go and they form a plexus around the duodenum. Those plexes also supply the papilla. Again, just to recap on the vascular supply of that's the celiac trunk, gastroduodenal artery, pancreatical anterior and posterior superior pancreaticoduodenal artery, and the inferior anterior and posterior pancreaticoduodenal arteries. They form the plexus around there. Now, interestingly, the average length from the opening of the duodenal papilla to duodenal artery is 36.5 millimeter, which is quite a long distance between the tip of the papilla to the major artery. So when we are performing a sphincterotomy, there is plenty of leeway there. However, in a small percentage of cases, about 5%, it runs within the region of the endoscopic sphincterotomy. And those are the cases where it can cause major bleeds. The maximum diameter of the arteries in the plexus is about 1.6 millimeter. However, the average diameter is around 1 millimeter. So these are fairly small blood vessels. The risk of hemorrhage from duodenal papilla due to endoscopic sphincterotomy is very low. So papillary arteries, which supply the duodenal papilla, originate from three major sources. These are communicating arteries from the posterior and the anterior pancreatico-duodenal arteries, which form arcades. Again, just the same picture. So the majority of the arteries which are supplying the papilla are either in the anterosuperior or the posterior-inferior quadrants of the major duodenal papilla. Therefore, the 10 to 1 o'clock positions are relatively free of the major vessels. Now, there was a study done on the through microscopy and microdissection, and it was found that only 10 and 11% of cases, the papillary arteries were in the area of the endoscopic sphincterotomy. It was considered that the relatively vascular free area in the papilla was at the 10 and 11 o'clock position, as opposed to the 11 and 1 o'clock position that we use for the sphincterotomy. So in case we are worried about causing hemorrhage, it's always better to err on the side of going more towards 10 o'clock than towards 12 o'clock position. I'll very briefly touch on the various types of papilla because I am aware that one of my colleagues is going to talk about cannulation, and I think it will be more relevant for that. But I'll just, there was quite a large study done by Harrelson from the Scandinavia Association of Digestive Endoscopy. They carried out a multi-center study in the Scandinavian countries and looked at over 1,400 patients consecutively undergoing ERCP. And they noted the various types of papilla that they encountered. And in fact, they classified the various papillas into 4 major categories. And the first major category was the type 1 was the normal, which one would term as normal papilla. The second one was termed as the small papilla. The third one as the pendulous or the floppy or the protuberant papilla. And the fourth one was the one which was classed as creased papilla. Now, there were no significant differences seen between the different types of papilla regarding age, sex, previous cholecystectomy rate, NSAID use, or protective pancreatic stent. So they were quite randomly distributed amongst the population, apart from the creased or rich papilla type 4, which was found mainly in younger patients and in patients who had primary sclerosing cholangitis as an indication for ERCP. So that was the only difference that was observed. Apart from that, they found that the small type 2 papilla and the protuberant or pendulous papilla, which is the type 3, were more difficult to cannulate, and it took more time. I'll quickly go through that because I don't want to spoil it for my colleague. Another picture of the regular type of papilla that we would see, the small papillas, the protuberant papillas, and the creased papilla. Now, my only criticism of this classification is the fact that they missed out on the peridiverticular and infradiverticular papillae, which are quite commonly seen and which can be a challenge to cannulate at times. And another type of papilla, which is known after this dog, and you can, from the folds of, this is Sharpe, it's a Chinese, it's a special breed of Chinese dogs, and they have these folds around on their coat. And you can imagine coming across papilla looking like that. Now, minor papilla is also called accessory pancreatic duct of Santorini, is 2 centimeters proximal and slightly anterior to the major papilla. It is patent in 50% of cases. Pancreatic tissue is also noted in about 80% of the cases in minor papilla. Generally, I would regard that as a no-go area for most of the endoscopists here. Only we use we cannulate minor papilla in very special circumstances, and I think it should only be left to the experts. Brief mention about pancreas divisum. This is failure of the ventral and dorsal pancreatic ductal system to fuse because embryologically, if the fusion doesn't take place, it results in pancreas divisum, in which case the majority of the pancreas is drained through the accessory pancreatic duct into the minor duodenal papilla. So, as a result of the pancreas divisum, pancreatic secretions from the uncinate process and portions of the pancreatic head drain via the major papilla, via the duct of Wirsung, and whereas it is separate from the remainder of the pancreas, and it is a relatively common condition. Most of the time, the patient is asymptomatic. In certain circumstances, they may present with recurrent pancreatitis. Now, that is what happens in the pancreas divisum. The dorsal duct, our main duct of Santorini, drains directly into the minor papilla, whereas the small, the ventral duct or the Wirsung duct goes into the major papilla. Another picture of the pancreas divisum. And I'll just give you how to diagnose pancreas divisum on an MRCP scan. You can see the pancreatic duct going and crossing the common bile duct to open up into the minor papilla, which is there, whereas the common bile duct and the accessory pancreatic duct open into the major papilla. It is a very telltale sign. And again, another picture image of the major pancreatic duct going into the minor papilla and the common bile duct going into the major papilla. I'll end my talk here. Thank you very much for your attention. Sorry about the delay caused by my lack of IT ability. Thank you very much.
Thank you, Waqar bhai. Thank you very much for a very nice and elaborative talk. I know that being a clinician, it's always difficult to go towards the basic side, and you've done an excellent justice to the topic. Understanding the anatomy and bringing the anatomy to the bedside of the patient, meaning by emphasizing the applied anatomy, that's a difficult task. And I'm sure that the audience would have enjoyed that. They must have been benefited from that. There are certain queries which have been raised by a few of our colleagues.
Yes.
First is, you have mentioned about the anatomy of CVD opening and pancreatic duct opening, and you've mentioned that there are 3 types of openings. Now,
yes.
Is it possible that for example, if we want to access the pancreatic duct on day 1, we're not able to access the pancreatic duct? So the question is, should we do a small sphincterotomy and leave it open so that we may be able to access the pancreatic duct at a later stage, or you suggest something different?
Yeah, I mean, it is Murphy's law. When you want to go into the pancreatic duct, you find it difficult, because most of the time when you are trying to get into the CBD, it's exactly the opposite. But I try to use sometimes I use a normal ERCP cannula, because that usually the direction is such that it helps getting into the pancreatic duct. Most of my cannulation is wire guided, so somehow or the other we try to do that. Yes, one can do a sphincterotomy, and most of the time the sphincterotomy will separate out the 2 openings. But then it depends on if it's a common channel, then it might not help. But yes, I mean, you use various maneuvers, and the one that I tend to use is the use of just an ordinary old style ERCP cannula, which usually gets me into the pancreatic duct. I don't know, Saad, from your sick bed, what do you suggest?
No, I agree with you. I use the regular cannula. If I want the pancreatic duct, it would be always ready. I will always go with the sphincterotome. and I
Yes.
try the regular cannula, like you said. But if I don't get in and I really need to get into the pancreatic duct and we are doing pancreatic, this is the pancreatic ERCP, then I would do a sphincterotomy, because almost always in my practice, it becomes very easy to actually get into the pancreatic duct.
Yeah.
I remember sometimes, if you can't, with your experience or Rias's experience, and this is something that I was told by one of the experts, that if you can't get into the pancreatic duct after so many years of experience, then think pancreas divisum. And the reason for that is that quite often the duct of Wissing is actually is very strictured, and so you can't just cannulate it, and so hence you have to think about it. We obviously see a lot of pancreatic cases. In fact, I think now for the last 2 years, I do more cases are pancreatic than actually biliary in my practice.
Yeah.
So this is what we do, and I totally agree with you.
Yeah. Thank you.
Waqar, there's a question from the audience that is it essential that every time you have a pancreativism, the patient should be expected to have pancreatitis as well?
No, that's a bit of an overstatement. I mean, they don't normally get it, and I mean, it is one of the causes of recurrent episodes of pancreatitis, but not in every case. So only those cases are investigated by doing minor papilla, pancreatography, where there is recurrent history of recurrent episodes of pancreatitis, and one suspect stenosis of the pancreatic orifice, in which case minor papillotomy or sphincterotomy would help.
May I just add something, Waqar? I know this is your practice, but quite often here it's not when I see patients. I'm sure Rias would agree with that. And I now, as a standard practice, always have an MRCP with me. And the MRCP will tell you whether the pancreatic duct is actually abnormal. If this is recurrent pancreatitis and you have pancreas divisum and you feel that there is nothing else to explain, then yes, you would go for it. Otherwise, an MRCP would clarify whether you really need to do anything about it or not.
Yes, we normally
and actually help you. Also helps you as well, you see.
I normally, all our patients have MRCP, almost all of our patients have MRCP before they undergo ERCP. So usually CT scan and MRCPs are done before that as a roadmap.
Yeah.
I think for pancreatic diseases, yes, it is very important to have MRCP before one goes for the ERCP.
Because with pancreatic work, most of our work is done by, there are only 2-3 of us who do it. And all the cases are very well planned and investigated before we touch the pancreatic duct.
That's right. The message is respect pancreas at every cost. Otherwise, pancreas goes inflamed, your endoscopic practice is going to go down.
Absolutely.
Because there's another question from the audience that why do we get the diverticulum, especially the outside diverticulum, in the elderly age group and not in the younger age group? Can you explain that? Why do we get diverticulum in the elderly people and not in the younger people?
I don't think there's a definite explanation for that, but there has been association between diverticulum and stone disease as well. And though we do come across, I mean, on a fairly regular basis, I see diverticulum in fairly young people as well. But no, I mean, there's no sort of scientific explanation for it. Sometimes when it's seen in stone disease, the assumption is that, because of increased muscle contraction or biliary colic, it might, result in diverticulum. But no, I don't have any answer for that.
Saad, do you have any comment?
Yeah, no, not all. But I think it might be very similar to what happens in the colon. It may be something to do with the anatomy in that area with age that becomes weaker, because not everybody, like Waqar said, patients have stone, but not everybody does. But it's almost always, on majority of the cases, we see it in elderly. So it has to be something that that obviously is more likely to be age related. No, I don't know why.
Yeah, that's right. I agree that possibly it's more to do with the weaknesses in the muscles, and with the aging, those weaknesses become more prominent, and the outpouching becomes more and more prominent with the passage of time, and the explanation can be in context to that. Now, why do we get more number of stones in people who are suffering from diverticular disease? to be honest, still it's a matter of speculation rather than actual evidence behind that. Mm, Waqar, you have suggested that one needs to do the papillotomy or sphincterotomy between 11 and 1. Is that correct?
Normally, I mean, that's a teaching that we do it between 11 and 1. That I've also done it like that. But just going through the anatomy of it, it feels the observation they did, because they looked at specimens. Mainly, they were cadaveric specimens, and they used both microdissection and microscopy, and they found that the least vascular part of the papilla was in the between 10 and 11 o'clock position, rather than 11 and 1 o'clock.
So, meaning by that, the papillotomy should be directed a little
more toward the left
side.
Yes.
So one needs to go a little more counterclockwise rather than going clockwise while doing the papillotomy. So this is the message that you want to give.
That's right.
If the person starts bleeding, where exactly will you like to inject on the papilla in terms of anatomy?
I normally usually, because it's mainly the tamponade and the relative ischemia that you want to create. So as you know, trying to inject with a needle through a side wing scope is always a bit more challenging than. So I try to, wherever I can get into the papillary tissue, I inject there. And as the blood supply is mainly provided by the arcade of arteries surrounding it, it would work, because once the adrenaline diffuses into the tissue, it would cause relative ischemia and tamponade. So I think wherever you can get entry into it, it would work. In cases of massive bleeding, as you all know, we tend to resort to using a fully covered stent.
Saad, what is your comment on this?
I think one of the things, obviously, like Waqar said, sometimes it's very difficult, but you try and aim towards the 10 o'clock position, which is where quite often you can actually get in, and you're away from the pancreatic duct as well.
That's
so
right.
I generally, if you can see where the bleeding is coming from, you just go over that and just inject and create a tamponade effect. But you just need to be very careful that you don't want to be close to the pancreatic duct. You don't want to create a tamponade there.
That's right.
There's a comment from Dr. Atta from Newcastle upon Tyne. He has shared his experience, his observation that the Olympus sphincterotome tends to go to the left and the Boston tends to go to the right. Do you agree with that?
I do not use the Boston as much. I mean, that's the dream dome, isn't it? Because I use it. It's more maneuverable and it's a smaller sphincterotome. But normally I prefer the Olympus because it's got a bigger cutting wire and gives you a generous sphincterotomy. So that's my excuse. But I know that the dream dome is more maneuverable. You can move it around more.
Waqar, there's a question from the audience. What do you think? The blood supply of the papilla is more from the superior arteries or from the inferior arteries? Meaning by, is it more from the celiac trunk or is it more from the superior mesenteric
I think it's mainly from the celiac trunk. But I wouldn't be surprised if you get, branches are from the
people tend to bleed from the inferior part of the cut surface, but most of the time the people tend to bleed from the lateral lip and more towards the upper side rather than from the lower side. So whenever one has to apply the hemostatic tool, it's best to apply it on the superior and lateral side rather than on the inferior side. But obviously one needs to identify the bleeding point carefully and clearly before trying to apply, especially the thermal coagulation.
That's true.
I'm concerned about thermal coagulation in the duodenum seriously. After you've done a sphincterotomy, you actually now literally have no space. And so I personally avoid any thermal coagulation here, because quite often you can get away with without doing all that. And personally, I'm too scared in the duodenum. Once you get it, it's literally, once you've actually gone and seen in the operation theater, if you do it in live patients, if you put the scope in, my God, when you look at the scope coming into the duodenum, you feel as if there is hardly anything. And after that, you feel really scared doing anything like that. And I don't know, but I don't have any experience of thermal coagulation in the duodenum. to be honest.
No,
I've
I
used
don't use
always
that.
injection.
Well,
I mean,
gold
when
probe
you
can be used.
hemospray, I mean, one can use hemospray. One can use, if it's a massive bleed, one
That's
can use
also
a
what.
fully covered stent. Or if you can use a clip, the clip has the advantage that in case you want to go for interventional radiology, it is a sort of a target, it sets like a marker for the radiologist to target his embolization there.
Yeah,
I
I think
agree.
clips. Yeah, if clips are used, clips. I agree with you, but my only question, Waqar, is because I don't use hemospray again. How much are you worried about the pancreas?
I mean, to be quite honest, Saad, I've hardly ever used hemospray. If I can't control it with the injection, I just put a stent in.
Agreed.
Okay.
Stents work
And,
very
and
well.
and where does clip come in your practice?
Very rarely.
Well, yes. When do you use clips?
I think I tend to use clips more frequently. If I'm basically a clip person. If a person is bleeding, I prefer applying clips rather than going for hemostasis, the thermal coagulation.
Yeah,
For
well,
the
that's
simple
true.
reason that if a person stops bleeding, it's going to stop bleeding right in front of my eyes immediately after I've applied the clip. I know clip is more difficult to deploy. It needs more space and more maneuveration of the tip of the endoscope. But then, if they have been deployed correctly, the results are immediate, and one can see the outcome, and one can safely come out, take out the endoscope after application of the clips.
Sure.
I think it's
Yeah.
already 7,
Agreed.
and we come to the end of this webinar. Next week, we are going to have a webinar on endoscopic anatomy of the pancreas, and our Indian colleague Bhattacharya is going to speak on that. Thank Dr. Waqar for sparing his time. I know it's a family day. You have taken your time out from the family activities. I'm really thankful to you for giving a wonderful talk on ERCP anatomy of the ampulla. At the same time, I'm thankful to my co-host, Dr. Sadnias, who was sick, who was suffering from upper respiratory tract infection, but he spared his time to come to the stream for sharing his views and posting it. I'm thankful to all the participants. I'm thankful to the Wilson for providing us with a platform. And see you next week. Take care. Allah Hafiz. Bye-bye.
Hafiz.